You should be able to see the BNF online now.
Yeah.
Okay. So these are all the sections within the BNF. I know we've already been through the book, which kind of goes through it, but I just thought it might be a good idea to just kind of pick out the different sections within it. So these are the subsections. Dyspepsia and gastroesophageal reflux disease, otherwise known as GORD, yes? G-O-R-D.
Yeah.
What is that, guys? Yeah, so there's two things with GORD, yeah? One is the overproduction of protons in the H plus ions or whatever in the stomach, so you're making too much acid. And then the other problem is the acid then goes up into your esophagus and then touches on like the more delicate areas within the gastrointestinal tract, which causes a burning, which can be painful. So what environmental things can cause GORD? Good. Spicy food also. One thing that causes the sphincter to relax is alcohol. Yeah. So if people are drinking lots of alcohol, it can weaken the sphincter, which protects the upper esophagus, and then the acid kind of goes up into it. Also, being overweight can cause it, and yeah, lots of dietary factors. How do you treat GORD? When I say treat, the first bit you should be saying is healthy lifestyle. Yeah. So you should be like, your big fat mama, go to the gym, work out, lose some weight, change, stop eating your Pringles and your Doritos and whatever, start eating some green stuff. Yeah. So that's your first bit. Then you're right. Then the next bit, you can use antacids, you can use, calcium ions or whatever, Gaviscon, which is good. What if you give me that and it doesn't work? What can you as a pharmacist give me apart from Gaviscon and all of those like antacids? What is this? Helicopter pylon? What is this? So gastric and duodenal ulcers. And that's the triple therapy, which is PPI, which could be omeprazole, lansoprazole, then clarithromycin, and either amoxicillin or metronidazole. What do you guys know about this drug, metronidazole? The way metronidazole and disulfiram work is that if alcohol does come into your system, it creates like an acute sensitivity to alcohol. It basically blocks the processing of alcohol in the body by inhibiting a certain enzyme, and causes like unpleasant reactions when people drink. So you got to know that disulfiram like effect and metronidazole are one and the same. And the way that antabuse works is if you're taking a tablet and then you take alcohol, it's kind of like buprenorphine almost, like it stops them from abusing. What's the main side effect of NSAIDs? So long-term ulcers as well. Why are ulcers why is ulcer a scary thing? You can get an ulcer which can burst the gastric lining, and you can start bleeding into your stomach. Yeah, if you start bleeding into your stomach, you're in a lot of trouble. It's very difficult to cure. This is very interesting, which they can ask you as well. Patients at high risk of developing GI complications with NSAIDs include those aged over 65 years of age, or with a history of peptic ulcer disease or serious GI complications. For that reason, they're usually prescribed in people who are higher at risk, i.e. people over the age of 65, with H2 receptor antagonists like ranitidine or misoprostol. Oh, that's interesting. Do you guys know what Arthritek is? Okay, misoprostol is something called a prostaglandin analog. And what prostaglandins do is they protect the stomach. So Arthritek is a combination of diclofenac and misoprostol. So it's an NSAID and it's got a prostaglandin analog. So the idea of Arthritek is you're giving a diclofenac which has inherent NSAID ulcer making possibilities, but you're giving misoprostol, which is the prostaglandin analog, to protect the stomach at the same time. The way I remember Crohn's is it's just a chronic inflammatory bowel disease, which includes ulcerative colitis, so UC. Good to know. Lots of people are getting this nowadays. And the way that you treat it is you can use steroids, which will change the inflammation response. Aminosalicylates such as mesalazine, you often see that as like an MR prep. And then like as a last line, because it's inflammatory, it's kind of immunological. So end line, they start using like pretty hefty like immunosuppressant things like azathioprine or methotrexate. Horrible disease. Okay, so that's gastrointestinal. That's all you really need to know. It's quite good, this site. It's got like, it highlights all the good stuff.
What site's that? Just BNF?
Yeah, BNF Online. Yeah, no, the hard copy's good, but can you see this bit here?
Okay.
That's quite cool, isn't it? This bit under this chapter also includes drug management of the following.
Okay.
These things are very important. What is hypertension? When someone comes into your pharmacy and has got a blood pressure of 192 over 90, what do? You take a few more readings. With blood pressure stuff, yeah, you before you take anyone's blood pressure, you first ask them, have you been drinking lots of coffee today? Because that can cause, do you take any medicines? That can cause. Have you done any kind of like physical exertion? And what you do is you make them wait for 5 minutes. If it comes out that it is 197 over 90, you go, all right, chill out for a minute. Are you nervous? People often, when they see pharmacists or doctors, they get a bit worried. Sit them down. 5 minutes later, take another blood pressure test. If that comes out and it's still like 197 or over 200, you call an ambulance. Well, it says it here actually. Look, sorry. Clinical systolic blood pressure over 180 is a clinical emergency. It's called a hypertensive crisis. There you go.
Yeah.
But it's almost like a paradox in like a spiral, in that if someone comes into your pharmacy and then they're like, oh, I've got 197 blood pressure, and then you take that and then you go, oh my God, you're going to die. What's that going to do to their blood pressure if you say that to them?
Increase it further.
Exactly. So what I would do is just like, oh, it's nothing, it's absolutely fine, nothing to worry about, chill out, relax. 5 minutes later, take another one. If it comes back, then I would ring an ambulance. Hypertensive crisis. Interesting. The way that nitrates were found that they lower blood pressure is in America. There are lots of miners who use dynamite to like blow up mines and get gold and things. What they found was these miners had really, really low blood pressure, but they also had really bad headaches because of vasodilation within the brain causes these headaches. What's heart failure? Yeah, so it's kind of like opposite to hypertension in a way. Not really, but it's the heart's not strong enough to pump all of the blood around the body. So the treatment for chronic heart failure aims to relieve symptoms, improve exercise tolerance, reduce incidence of acute exacerbations, and reduce mortality. ACE inhibitors. Name an ACE inhibitor, guys. Ramipril. What is a side effect of Ramipril?
Cough.
Very good.
Yeah.
Dry cough. And also angiotensin 2 receptor antagonists. Diuretics is good to know though. You need to know these off by heart, guys. So thiazide's the most, yeah, thiazide's the most popular is going to be bendroflumethiazide. Loop is going to be furosemide, and there's other ones. I'd probably learn what sodium and potassium levels should be.
Okay.
Yeah. What's hyponatremia, guys? This is interesting. What is anaphylaxis? It's like a super allergy, very, very rare. What do people have anaphylaxis? Anaphylaxi? I don't know. What causes it? Nuts. Bee stings? Yeah, that's a biggie. And it's treated using adrenaline, and you can use certain antihistamines, but the adrenaline's like really quick acting. So the main thing you've got to look out for in anaphylaxis is swollen lips. You get conjunctivitis as well. If you're thinking they're getting inflamed lips, you know, where else is that inflammation going? Is it going into the airways? You know, what would happen if that patient stops breathing? Got to keep those in mind. I think this is quite applicable to pharmacy, cough suppressants. We've talked about this quite a bit. What's the difference between Folcodine and codeine, guys? Codeine may be effective, but is constipating, cause dependence. I'd say codeine causes dependence. Don't give it to people because people abuse it. However, dextromorphan and Folcodine, low dependence. You could like drink pints of it and it wouldn't get you high. Okay, this you need to know as well. So what is hyponatremia, guys? We already said. Yeah, okay. You may have seen this in your hospital like placements. What happens is these old like elderly ladies often get depressed, unfortunately. And what happens is the doctor then puts them onto SSRI. What's an SSRI? But what happens is they get so these old ladies get put onto fluoxetine or sertraline, as you said, or citalopram. Citalopram by far is the most popular antidepressant. SSRIs, write this down, cause hyponatremia. Hyponatremia, low sodium in elderly people, makes them confused. It's interesting working in hospital, like what people come in, and one woman I remember, she was like an old biddy and she was on 20 mgs citalopram every day, and she started getting hyponatremia, so low sodium. She was standing at the top of the stairs and then she got dizzy. She fell down the stairs. What bone condition do elderly women often have? This is what I was saying about different antibiotics for different conditions. So another one you kind of need to know is metronidazole. Metronidazole kills anaerobic bacteria, so it's mainly used in ear, nose and throat. It's good to know. Penicillin is usually given for the throat. And then, as I said, any kind of skin conditions, they would go for Fluclox. What's the difference between pharmacodynamic interactions and pharmacokinetic? Easy peasy. Pharmacodynamics is like, I'll give you one. What if someone was taking atenolol and salbutamol?
Or like a synergistic effect.
Yeah, synergistic. So it's if one, because it's an antagonist and an agonist, that's a dynamic effect. So because they've got one action which is doing one thing, but the other drug does exactly the opposite action, that's a pharmacodynamic interaction. Pharmacodynamic interactions between drugs have similar antagonistic pharmacological effects or side effects, maybe due to competition at receptor sites. The way that the BNF deals with malaria is it lists, it's really horrible, it lists the the countries, where is it? It lists the countries where it should be taken. Oh, it isn't on. It doesn't do it on the online BNF stuff. Okay.
Oh.
So it does in the book though. So what you need to know about malaria. So name me 6 treatments for prophylaxis of malaria. There's 2 types of antimalarials. There's chloroquine and palindrine, and then there's the others, which are doxy, malarone, and lariam. Yeah, so you've got to think of those in 2 different categories. Palindrine and chloroquine are less effective because there's more resistance to malaria around the world. Those are only really effective in like places like Sudan, Egypt, and southern Mexico. Very, very rare. But 90% of all other places, there is chloroquine resistance, which requires, as I said, the top 3 hitters: doxy, lariam, which is mefloquine, and malarone. So the question was, if someone's going to Ghana, what antimalarial would they need? And it's not the fact that, oh, they're going to Ghana, they have to have doxycycline. It's more, well, there's resistance in Africa, yeah?
Mm-hmm.
Therefore, they need to have one of those 3, doxy, malarone, lariam, yeah?
Mm-hmm.
But what will happen in the exam is they'll give you a patient scenario. So, all right, Merlin, you've got to tell me the answer to this. I am a 11-year-old child. I've got epilepsy and I'm flying to Ghana. What antimalarial can you give me? Firstly, as I said, there's resistance in Ghana to chloroquine. So what does that rule out? It rules out palindrine and chloroquine. Okay. So the only other 3 options I've got is doxy, malarone, lariam. Yeah? Lariam, mefloquine, because it's a quinine derivative, you cannot give it to epileptic people. Okay? So the child is epileptic. You can't give it to people who have got anxiety, who have got depression, or even have a family history of epilepsy. Also, I said that the child is 11 years of age. What do you know about doxycycline? So what is the only antimalarial you could give me? No. You can't give lariam to patients who have got epilepsy. Yes. So malarone is your only option. Can you give doxycycline and to someone who's on a oral contraceptive? So they used to say that if you take a broad spec antibiotic, it will kill the flora in the stomach and prevent the absorption of contraceptives. But now that's changed. It's changed so that you can take doxy. So just to kind of finish this bit off, you've got to remember the main things you're looking for are epilepsy. And the reason why it's epilepsy is anything that has chloroquine in it, i.e. chloroquine or the palindrine or mefloquine. Mefloquine is a chloroquine derivative. You cannot give it in epilepsy. You've got to know that people who are splenic, i.e. they don't have a spleen, they are at higher risk of malaria. Renal impairment is also a thing about chloroquine and malarone. And then pregnancy is a good thing to know, in that chloroquine and progranil can be given in the usual doses during pregnancy. But what's the problem with chloroquine and progranil? There's resistance, so it's not really applicable. You definitely can't give doxy to a pregnant woman because the fetus has got calcium, and with malarone, it's there's not enough proof. So if someone comes into your pharmacy and they go, I've got a fever and I'm sweating and I've just come back from Ghana, you know, what are you thinking? The thing that you've got to keep in mind is like a fever and the kind of sickness that comes with malaria is up and down. So if they've got a continuous fever for a week, it's probably something else, probably, I don't know, some sort of infection or something. But if they get a really, really bad fever for, let's say, a day, and then day 3 it's fine, and then it comes back on the 5th day, and then it goes away, and then it comes back, that is called differential diagnosis of malaria. Because when you say fever can be anything, it's generalized. But if you want to know it's malaria, you look for this kind of like up and down kind of thing. If you can look at a website called fitfortravel.nhs.uk, you can see that on my screen now, and just kind of get used to looking at different countries. So for instance, this is Ghana. That's a malaria map of Ghana. So it tells you that there's malaria all in those countries. For instance, though, keep in mind, if you see a country like this, Cambodia, which used to be called Kampuchea, can you see this area doesn't have malaria?
Yeah.
Okay, so there's quite a few reasons for that, but you just got to keep in mind, you know, the BNF will say the whole of Ghana has malaria. However, when it goes to Cambodia, it will say Siem Reap and Angkor Wat, where 90% of people go, and Phnom Penh, the capital in the south, there's no malaria. But you got to keep in mind, if they're going outside of those areas to like Kampot or Sihanoukville, then they might need an anti-malarial. Visit pharmacycpa.com for the full video series. As always, for more information, please subscribe to our YouTube channel, join our free PCPA course, join our Facebook group, or subscribe to our blog.